I call to order the Health and Human Services Oversight Committee meeting for Friday, October 24th. Would the clerk please call the roll?
Okay, Senator Gray. Senator Avard. Not here. Senator Rosenwald.
She's here.
Yes. Perhaps she's capable next week.
She is capable, but...
Okay, but will be. Okay. Representative Pearson is here. Representative McDonald is not. Representative Mooney is not. Representative Weber is present. Representative Woods, Representative Mullen Kane, and Representative Seaworth are all present.
Representative McDonald has a county executive committee meeting. Representative Mooney is squiring school children from her district around the State House, and both asked to be excused. And any alternates are now, should we have a vote, moved up to regular members. Senator
I'm
Gray.
looking out at the audience. I have a question as to whether this is, the boys on our right and the girls on the left. But see, you were behind somebody, or whether there's a reason why someone is that side of the room. But
More power to you.
A little levity to start.
Do I have yes, okay, we've got the roll. I'm getting ahead of myself here. Approval of the draft minutes from September 26th. The chair recognizes Senator Gray.
I moved to accept the minutes.
Do I have a second?
Second.
Somebody seconded. And all in favor?
Aye.
Opposed? Thank you. Before we move into the commissioner's update, I asked to be and was named a member of the Palliative Care Hospice Study Committee, chaired by Senator Avard, and it was interesting not to be the chair of something, except on Wednesday I was, because he wasn't there. And one of the thoughts that I believe it was Representative Woods brought up was, could we not have an ongoing study on this, because this is a changing thing. And so I'm just putting it out here so that next month we can discuss it, and in December, when we have a presentation on this, we could vote on having a subcommittee on palliative care and hospice that would report back to us. Or it could be a runner, that is to say, it could be an agenda item that we would look at every 2 or 3 months. But I think there is good reason to have such a continuing thing. We certainly came up with numbers of questions that we saw were evolving. With that, the commissioner's update. And we have a couple of folks here. The JV? Okay, that's Associate Commissioner status, JV. Okay, and we have 2 of them. And you know the most important, done. You see the red light?
Yes.
Good, thank you.
Chris Santinello, Associate Commissioner.
Tricia Tilley, Associate Commissioner.
So I think I will just start. I just wanted to give a quick high-level overview of what we are doing, hopefully as a contingency plan for SNAP. As people are aware, with the federal shutdown, a number of the benefits are questionable if they will be available. And so we received a letter from Food and Nutrition Services, which is part of USDA, United States Department of Agriculture. The letter was dated October 10th. We received it on October 12th, indicating that there may not be enough money in the SNAP budget to cover November benefits without an additional appropriation from Congress. And so we have asked multiple questions of FNS. We have not received any answers. We understand they will be sending guidance out, but we have not received it to date. In New Hampshire, we have to transmit our November files for people to receive SNAP on Friday, October 31st by 6 p.m. All states have been told to hold their benefit transmission until further notice. When we forward our benefit file, benefits in New Hampshire are always available on the 5th of the month. So we started yesterday sending out letters to participants, making them aware that we are not sure if benefits will be available, and we are currently working on a contingency plan with the New Hampshire Food Bank to increase mobile food pantries, and also there's a number of standalone traditional food pantries that would have SNAP participant-only food pantries available to them if benefits are not available.
Any questions? Senator Gray.
You didn't speak about the special fiscal meeting that's going to happen on
Yes.
Tuesday and has already been announced.
Yes, I wasn't sure where things were. We're working with the governor's office to make sure we have the right legislative approvals. And like Senator Gray mentioned, there will be a special fiscal committee meeting because in order for us to bring the contract to governor and council on the 29th, we need to transfer dollars within the department and need fiscal approval.
Senator Rosenwald.
Thank you, Mr. Chair. So that fiscal item is to transfer $2 million. My understanding from Commissioner Weaver is that the SNAP program brings in $12 million a month. Can you talk a little bit about the potential gap
Sure.
of $10 million if this shutdown
Yeah,
continues through November?
It's significant for families. I do know that there is no other state, I think with the exception of California as of earlier this week, that is able to supplement the SNAP benefits. I mean, it is a federal entitlement as well. So we have about 42,000 households, which represents approximately 70 to 75,000 individuals. A large number are families and children. I don't have the actual breakout right in front of me. But the average benefit is about $300 a month, so there will be a gap for families. We are hoping that dollars will be released. I know it's hard, like with WIC, they keep on extending it, but because New Hampshire, we only do one issuance at the beginning of the month, we aren't sure exactly what that would look like if they did partial benefits or any benefits at all.
Yes, follow up.
Thank you. So let's say that the shutdown ends midway through November.
Right.
Would the department be able to load half a month's SNAP benefits if that money were released?
Yeah, if money is released, we would be able to load the benefits. Actually, that's what we're doing. We needed to get the work done for the contingency plan, and now we are working with our electronic benefit card vendor, because all of the benefits are on a card, to say, okay, what lag time do you need? How much time do you need to push benefits out? So if benefits became available, we would be able to transmit them onto the cards.
Thank you.
Any questions on this so far? No?
Great.
Okay, you
Thank you.
asked. of the
Thank you,
chair.
Mr. Chair.
Yeah,
Okay.
go ahead.
And thank you. Could you just explain a little more that the temporary appropriation will be to provide food at these pantries, or would it be to get? I guess I'm particularly concerned about WIC benefits being cut.
So I'm going to transfer that to Tricia. That's why you have both of us this morning.
Okay, so that the
under?
We're
WIC is
just
separate
doing
from SNAP. So
Yeah.
two complementary programs. SNAP serves 70 to 75,000 people across all ages, and it is a cash benefit. And as most of you know, WIC is a benefit for women and infants and children, so for pregnant women children up to age 3. So a much smaller subset, but 13,000 people nonetheless. That is a significant number in the state. The programs are run differently in collaboration, but are different in many ways. So they are both, one of the ways they are the same is they are both funded by the USDA, the United States Department of Agriculture. In WIC, we have received some additional money so that we can extend those food benefits until the 7th of November. So we have a week longer than SNAP for those benefits to be turned off. WIC across the country, some states have already needed supplemental funding to even get through October. In New Hampshire, we had enough money, we were able to balance it to get through the month of October. And we have been awarded a small amount of money to get through at least another week into November. That is not without difficulty, however. We are no longer able to fund the 4 WIC programs that are in community agencies around the state. So we are putting all the money into the food, knowing that those agencies, Greater Seacoast Health, Belknap Merrimack CAP, other CAPs in the program, may have to temporarily pause their in-person work with families. Again, another difference between WIC and SNAP. In the WIC program, you go and you meet with a nutritionist and you do one-on-one work. In New Hampshire, we have made the decision to put the money towards food, which is a difficult decision, but we know that that's everybody's priority, is making sure women and infant children have as much food for as long as we can. We anticipate, we have heard similarly from USDA, there may be a small amount of money that comes to us, but we don't know that yet. And so we have been part of the same announcement saying SNAP is going to end as of November 1st. If we don't receive additional money, WIC recipients will have until November 7th to use their food benefits as well. So again, 2 slightly different programs, all around feeding children, families, adults.
Any further questions?
Great.
Next subject.
Sure. So the second thing that we just wanted to bring to your attention today, if this was not enough to keep us busy right now of thinking about how do we make sure that we have benefits and food available for the most vulnerable in the state, we have a more exciting opportunity. I'll use the word exciting. Certainly a more historic opportunity right now in working for the Centers for Medicaid and Medicare as we work on something called rural health transformation. So as part of the federal One Big Beautiful Bill, there was a significant amount of money dedicated for states to support the infrastructure in our rural areas for every state in the country. And so for New Hampshire, what that means is we have had 6 weeks to work on a really comprehensive plan for up to $1 billion over 5 years. So $200 million a year is what we've been asked to budget for through a grant application, a cooperative agreement application. So we have been working with our communities to understand how do we best support 4 major delivery systems: our critical access hospitals, our small rural hospitals, our federally qualified health centers. Sure. Okay. Critical access hospitals, federally qualified health centers, community mental health centers. Okay.
I really need to get all 5 of them down.
Okay, great.
I've gotten through the critical access hospitals.
Federally qualified health centers.
Yep.
Community mental health centers. And EMS.
Thank you.
Great.
Sorry about that.
4, not 5. I just had to redo that math in my on my fingers right there. Yeah, Senator Gray is probably sad that our associate commissioners count on their fingers, but so we have worked tirelessly for a number of weeks now. The application is due on November 5th. We will be putting it in on November 3rd. And to get feedback from all of our rural communities and our community partners, and especially those 4 delivery systems, about what would be transformational for them. There are a number of pretty strong bookends around what the funds can and cannot be used for. This is unlike ARPA, where we just could make up a great idea and run with it. We really need to be a little bit more tailored. And we're focusing on thinking about, a number of ways to, let me just get my notes out here because I ran a little bit shy. I'll talk a little bit about the feedback we've gotten. We were able to put out something called a request for information. So we posted on our website, essentially a survey, in which we welcomed opportunities for people to say what would be transformative in their communities. We know that we had over 4,500 hits to our website, over 700 people engaged in that survey, and we had over 200 completed surveys done for us. We took in all of that information, as well as worked around the state convening folks to get other information, especially from those delivery systems and the community agencies that touch them, and have synthesized all of that information into a plan that really focuses on improving quality of care for all rural folks, in making sure that we have the financial stability of those facilities along the way. Those are really the 2 major things. Thinking about the way payment reform may work over the next few years, and ensuring that we really have those facilities open today, open tomorrow, and open 6 years from now. So the governor has our proposal, a high-level proposal. We met with her yesterday. We're very excited. The other piece of that is also workforce, because that's loud and clear from everyone. We can't do anything without workforce. It's significant, and especially thinking about resources for both our university system, UNH, and our community colleges are really big parts of that. So I will pause there. I don't want to take up more time. We have a very full agenda for you, but happy to answer questions.
Representative Weber.
Thank you. Thank you for taking my question. What about transportation? I'm also a member of the Commission on Aging,
Yeah.
and we've heard a huge
Yes.
conversation recently about how very much of a barrier transportation is, even when care is available. Transportation, if available, isn't always reliable. So
Yeah.
we'll address that.
100%. And we heard that loud and clear as well. I don't think you can go out into the community and ask a question and transportation doesn't come to the top of the list. Transportation, housing, childcare. We all know that those 3 things come loud and clear. This particular funding source is not considering housing in particular, so that's off the table. But for transportation, we do have some proposals that we are working for to really support the existing statewide coordinating council that works on transportation, really supporting them to think of innovative ways, promoting sort of tech around, is there an app system we can use around to, think differently about the way that we can increase the reliability of transportation in the community. We're going to be working closely with the Department of Transportation as well. So that's certainly contemplated in this grant. And while not specifically called out by CMS as a pillar of something that they want us to address, it is not unallowable. It is not disallowable. So we've incorporated it into our proposal.
Senator Rosenwald.
Thank you. Thanks for taking my question. In another study committee, Senator Gray and I learned that really we're guaranteed $100 million a year, and the other $100 million is split into 2 pots, one being for rurality, which I didn't even know was a word.
It's a great word.
That we're going to struggle to meet, but the other one for policies and our ability to implement them. My question is, how are you prioritizing your proposals? Would you do everything if we got $100 million and just scale it back by 50%? Or are you proposing certain things that you would do if we got 100 million, and then add-ons if we got parts of the other 100 million.
I think you have a bug in our office right now because that's the fancy math that we're doing right now.
I don't have fancy math anywhere like you account.
So you've identified one of the huge challenges. There are many challenges with this proposal. It is incredibly complex. It is complex even just by the scale of it. And one of the things that's complex about it is that we've been asked to budget to 200 million. We know we're not going to get 200 million a year, so we are budgeting to 200 million, but we're doing that calculus and working with our partners right now to understand, and we certainly know we have some sense of priorities and that we will move forward at the $100 million level. We will likely get more than 100 million. We have sort of a bets going on. I don't know if it's legal for me to say that, of what number we're going to land on.
Yeah.
Yep. Because you're right, for rurality and size, we are at a disadvantage because it's the hard number. It's not a proportion. It's just square miles that are rural, number of people who are rural. We are not Texas. We are not Alaska. So, we get down at the bottom of the list for that. The policy side that you noted is really interesting because you get essentially extra credit for certain policies, and New Hampshire actually does well on many of those, and some that are even newer policies for us to contemplate. There's interest in contemplating those, and those are things around scope of service for pharmacists, licensure compacts for physician assistants. We're happy to even though we're not there for those things, we get half credit if we say we're interested. And we know that we have partners in the Senate who are willing to advance those this year. And so if they move forward, we get the full credit. If they tank in the general court, they take the money back. They take half that money back. But to your other, so we will get more, assuming we have a fully compliant application when we submit it. I think we will get more than 100 million. It's unclear what that number will be. And then we will prioritize once we get it. There's going to be a negotiation. So I think we will also have feedback from CMS. We know what we would prioritize. CMS may also have ideas, and we work through that.
Follow up. Sure.
Thank you. So in terms of like workforce initiatives and where we teach nursing,
yes,
for example, at UNH, our understanding is that 40% of the nursing graduates immediately go work in Massachusetts.
Sure.
Are we contemplating some kind of, here's some help for your tuition, but you've got to stay and work here?
Sure. So this has also been complex. It's been an evolving feedback with CMS. So, for example, a project that you all know well that we do, state loan repayment, that is not allowable under this grant. So, loan repayment off the table. We were also told that straight scholarships in those terms are also off the table. However, we could do awards, and we can have lower tuition. So there are ways that we are working through that, and all of that CMS is requiring a 5-year commitment. So for those pieces that you get a 5-year commitment. So to your point of folks skedaddling, to Massachusetts, we would have, if you participate and you receive some of these supports, there would be an expectation for a 5-year commitment in New Hampshire.
Yes, me, yeah. Associate Commissioners, the great cry of rejoicing that welled up from the State House yesterday, of course, was the Senate Judiciary Committee passing unanimously House Bill 480 and putting it on consent. That is the Restoration of Competency pilot project co-sponsored by the honorable gentleman from Metropolitan Hampstead. I am wondering, since the pilot project, the bill says as funding becomes available, I'm just wondering if, since a pilot project could certainly be raised up in a rural area, some of the money to the community mental health centers could be used for this, as well as all the money we are trying to raise from private sources.
Sure. So that's certainly something for us to consider. I mean, one of the hallmarks of this particular program is also we have to show sustainability in every single thing we do. So again, the investments that we make, we have to have a plan of what happens in 5 years when those investments go away. But we'll certainly consider that as we are putting the final touches on the application right now.
I'll still give you that $100 million if I win the lottery.
Thank you. I'd
You're
appreciate
welcome.
that. We'd like to feed the people of New Hampshire with that first.
Absolutely. Anyone else on this? Saying none? Next. What's next? That's it?
Yes, that's it. That's all we have for you today.
2 commissioners, no waiting. Wow. Thank
That's
you.
great. We have Director Lippman waiting in the wings.
I know. He's on the boys' side of the playground, too.
Yes.
Yeah.
Thank you.
Thank you. And I used to say our old friend, but I want to say our dear friend, Mr. Henry Lippman. And I looked up what FACHE means, so I'm all set now.
One of my friends said, the pinnacle of your profession, you become a fake. But F-A-C-H-E, that's fascia.
I thought it was fascia.
Yes,
but okay.
you're right. But it just is a funny. I'm here, Henry Lippman for the record, State Medicaid Director, to give a quarterly update on postpartum. You should have a small slide deck in front of you. The first thing, I'm sorry? The map. Oh. Yeah. Okay, sorry. Yes. Having trouble? I'll grab one for you.
You know, you guys give us such a large stack, you know, showing us the cover page and allowing us a couple of seconds to get it.
Don't tell the executive council we're getting reams of paper.
Hey, I've already made a pitch for having the stuff. You know, we already have a website for the committee, and if there was a, you know, link where all of the stuff could be put, then you wouldn't have to print it. You know, everybody'd be able to go in and get it, and
That would be great.
amen.
Not on my watch. Go ahead.
So the first thing I wanted to just share was a map of which states have adopted the postpartum coverage that we adopted. And it's, other than 2 states, it's been adopted throughout the country. Both Wisconsin and Arkansas have had legislative efforts to adopt. Have been unsuccessful thus far to do so, but it's pretty universal at this point. So just the second slide, since we adopted postpartum coverage, which we reported earlier that we were required to do it by January of 24, we got it done by October of 23. So this represents the number of women that have delivered and been able to take advantage of the postpartum coverage since that time through May of 25. And that's a little over 2,300 individuals. And if you turn to the next page, there's a map that's kind of small with a lot of small dots on it. It's basically the dots represent individuals, the distribution of the 2,351 women that have been able to take advantage of the benefit. So you can see it's across the state.
While we're on that, these are numbers.
Yes.
Is there a similar map that shows percentages? Because certainly more rural places will have smaller dots, but I'm not convinced that's straight line across. Are there pockets where the percentage is higher?
I've not pulled that up, but I can do that and supplement it with a follow-up email to you.
Thank you.
So the most frequently accessed services for mental health services, followed by substance use disorder at 8%, Preventative services are 25%. Related to heart or hypertension has been 6%. We're still early in the program with respect to the Medicaid population and being able to derive analytics that I think are credible based on the number of people, but we're getting close to that level to be able to do that. But on the next page is public health data for the state, which includes all individuals, and you can see, the perinatal mental health conditions chart on the left, an increasing number of individuals with that condition, and then on the right-hand slide, you can see that those individuals who have that condition are more likely to have severe maternal morbidity. So that I think is important in terms of the investments that are being made in mental health and substance use disorder, and that I think the Rural Health Transition Program will also contribute to. One thing, not to add to what was spoke to earlier, but the mental health centers and FQHCs, no matter where they're located in the state, can benefit from that program as well. So that's a good thing too. And then the last page looks at the conditions of SUD, and cardiac services are important to improving on the morbidity side. And I think that Medicaid women have had a disproportionate share of the deaths that have occurred, and so I think looking over time, whether related to SUD, looking over time to see if we can make that Medicaid disparity between that and the rest of the population close would be something I'd hope we could see in this data as we get more mature data to share. That's what I had for today. Happy to take any questions.
Senator Rosenwald.
Thank you, Mr. Chairman. So we've had this program for 2 years. So if we have, I think you've told me 12,000 Medicaid births per year,
It's
I
actually
would expect to see
total births for the state. We're about 2,500 births per year.
2,500 births. So
for Medicaid.
does your
We have about
the 46%, your percent receiving services, is this just, does that really relate to the total number of Medicaid postpartum women who are receiving services, or is it a percentage of all of the Medicaid covered births?
it's the women. So we're tracking the data of the women who are having the postpartum coverage. That's of women who are postpartum coverage, that 46% accessed.
So 46% of women who give birth covered by Medicaid have received mental health services.
Yes.
Okay, thank you.
An observation, I followed politics all my adult life somewhat closely. And so when someone today throws in a conversation, oh, well, Democrats don't go for this or Republicans don't go for this, I have a history of knowing what that might actually truly mean. So do maps. And I'm looking at all these red states colored blue. In other words, this is not a partisan thing. This is everybody except one to one degree and one to a greater degree. This is people. This is us.
Yes.
So when people would say, oh, that's and name a party, I fact check that. And so I'm very appreciative that this is not just in states that are on one end of the spectrum.
No, it's definitely not. And some of the earlier states were actually red states.
Mm-hmm. This is true, by the way. As you probably know, I'm working to help raise up a greater mental health court. And that's what we're finding there too.
Yes.
So Just an observation. Thank you.
Well, thank you.
See you again real soon.
Yes.
Annual report on implementation of New Hampshire's 10-year mental health plan, Carolyn Lewis and Darrell Tenney.
Good morning. Good morning, Chairman. Good morning, committee. For the notes, my name is Darrell Tenney. I'm the Bureau Chief for the Bureau for Children's Behavioral Health at DHHS, and I'll have Dr. Carolyn Lewis give an intro.
Good morning. Carolyn Lewis, Bureau Chief, Bureau of Mental Health Services.
Just want to start off with a little housekeeping. We do have PowerPoints here. There's quite a packet in front of you, and I just want to make sure that you guys have them. Maybe the only ones in color, or minimal ones in color, but it looks like this. It'll say 10-year mental health plan. It may start, it's in a paper clip, and it may start with the actual 6-page 10-year mental health plan updates.
Well, we're not there yet. If you could,
There we go. Yeah, thank you.
yeah, and it's got a paper clip. Good.
Great. So we do have a PowerPoint to follow along. It is high level, so we'll kind of walk through some of those key updates at a high level, and this document's really available to complement in case there's any direct questions around goals. So we just want to first start off by saying thank you. Thank you to this committee. With the help of this committee, we've really been able to support and provide oversight to a plan that continues to support families tremendously. And with that dedication, investment, and maturing our vision, it's been able to allow us to show great progress across the system. And when you think about everything that's happening across the country and in our state, it's great to be able to see some of that progress on paper. So we've had a great privilege being able to pull this together and talk about this extensively. Part of that system. So I'll have you guys jump to page 3 on the slide deck. We want to talk a little bit about some system-wide progress at a high level, and then I'll transition a little bit into children's initiatives explicitly. So in front of you, you'll have those 6-page updates, but we'd like to highlight a few important update themes on slide 3 here, which includes how New Hampshire has moved towards a more integrated continuum of care. And there's a few bullets there. We wanted to highlight these key areas. Certified community behavioral health clinics show how behavioral health and physical health can operate as one coordinated system. Carolyn will talk a little bit more about CCBHCs. Over the past year, we've had a completion of a comprehensive assessment for assessment of the children's system of care, which has been tremendous in informing us about strategic priorities, and has really helped us bring those strategic priorities into the commissioner's roadmap as well. Really informed us around data infrastructure across hospitals, across community providers, crisis teams, housing supports, which really helps to capture the needs of individuals across our state, and helping to restructure the way that the state funds services linking payment to quality outcomes. So, these are some key areas. The result is that a system, it really helps the system to operate efficiently, shares information more efficiently and seamlessly, and really focuses on people rather than programs. And so a lot of our data has really helped to show us that picture, which has been incredible. So I'm going to have you actually, so slide 4, page 4 on the PowerPoint is more of a separator. So I'll have you skip to page 5 and talk a little bit more about children specific initiatives. So within the annual update, there are child and family focused initiatives connected to 3 goals, which are listed at the title page of this slide deck. That's coordinated continuum of care, prevention and early intervention, integration of peer and natural supports. These children initiatives are really embedded in several of the goals within the 10-year mental health plan. Prevention and early intervention remain central for children and families. We have continued to see increases in utilization in critical programs, which I'll call out and talk about a little bit here. But you'll see here on the left-hand side of the slide, programs like Fast Forward, Early Childhood Wraparound, as well as our Transitional Enhanced Care Coordination services continue to increase significantly and have served over 2,700 children and youth since the program's inception. There are several other references I'll make, a few other critical talking points that I want to share. Our collaboration with maternal health and early education is critical to point out here in the children initiatives. Utilization of tools, standardized assessment tools like the Child Adolescent Needs and Strengths Assessment Tool. We've continued to expand the use of that tool to ensure that we're identifying needs and strengths of youth more effectively, and those needs and strengths are shared across the children's system initiatives as best possible. I want to point out our collaboration with schools, school districts, really to ensure that schools are able to refer to a full continuum of care. Keeping youth in their schools and in the classroom for education is really critical for us. And the children's system of care initiatives are really dedicated to help students in school districts as much as possible. We are also providing strong support to those who assist families to navigate the system. So I really want to call out peer support roles. We do utilize family peer support, youth peer support as a critical component to the programs that I talked about a little bit before, Fast Forward, TREC, our Transitional Enhanced Care Coordination Program, and our Early Childhood Wraparound Program. So these have been incredible tools and components to help families navigate the system more effectively. So what these programs really help to do is to ensure that the children and youth are accessing community-based care. And that's really is our goal. We want families to be assessing community-based care as much as possible. And so a lot of our data points look at whether these programs are indeed keeping youth and families in their communities and at home. So we partner very closely with the Division of Children, Youth, and Families, of course, for youth with complex family needs, but certainly complex behavioral health needs as well. But what we're finding is that the connection to these community-based services really help to prevent youth from needing higher levels of care like residential treatment, acute psychiatric hospitalization. It helps to reduce lengths of stay when they do require a higher level of care, and reducing recidivism for readmission to a higher level of care in that.
If I can cut in at that point, this
Sure.
is one of my favorite topics.
Yeah.
Spend a nickel now to save a dollar later. Of course, you got to have the nickel.
That's right.
But still, as a principle, do you have any brief data that could back this up? Because I believe it, but I'd love to see some numbers as to spend a nickel, save a dollar.
Yeah, thank you. So I think the proof, some of that proof will be in slide 6. So I'll have you jump right there. How's that? All right. So we'll, I really wanted to sit here and drive home today that exact point. Prevention is critical. Early intervention is critical, and the key programs that I'm here talking about and highlighting have been very critical in ensuring that we're reducing those higher levels of care. So on slide 6. You will see our preventative efforts making that difference. You can see here the slide is representing both our Division of Children, Youth, or youth that are involved with the Division of Children, Youth, and Families, as well as our voluntary pathway for residential treatment through the Bureau for Children's Behavioral Health. And this is really showing the number of children in those residential settings in the significant decrease since August of 2024. And there's a lot of it, so I don't want to sit up here and take credit, have our community services take all of the credit. There have been pointed strategies through DCYF. DCYF's strategic plan has been critical in this endeavor, but the community-based services that are provided I have no doubt that they have impacted these numbers over time. So just throwing the numbers out there, you can see here, if it's small, kind of call them out. In August, on August 12th, when we did a point in time, there was 360 youth in a residential treatment setting. We pulled these numbers at the beginning of October.
Could we interrupt you for a second?
Oh, sure.
I have now completely lost my grip. Because I was following along the numbers on pages that were numbered, and they
Oh, I'm sorry
These are
about that.
unnumbered pages.
Yeah, they are unnumbered.
Right. I was writing and not looking. I am now looking and I am, okay, that's where we are.
Yes,
We
we're
are on
on, yeah, which would be
unnumbered
page 6,
six.
slide
Okay.
6. Yes. Thank you. So you'll see here, we in August 12th, point in time, 360 youth in a residential setting. In the beginning of this month, October 2025, we had 296 youth in residential treatment, and that's a significant decrease and what I consider a win for New Hampshire. These are higher level of care programs. Youth are not in their community. We're looking to ensure that these youth can be in their community as much
Where
as
are they?
possible. This number here. So when you're asking the 296
Okay.
individuals,
Yeah.
these youth are at various programs across the states, many of which are in New Hampshire programs, New Hampshire contracted programs, certified programs. Others may be in New England certified and contracted programs. Very few are in national programs.
Will any of these be in Hampstead, or are any of them in the open place in Hampstead presently?
There are a couple in the psychiatric residential treatment facility that would count within this number, but not the acute psychiatric hospital. It does not capture that number.
Okay, and how about the one that's going to be open soon? Would this be a catchment area?
Or if you're speaking about the psychiatric residential treatment facility, that is currently open today. You may be referencing the secure unit.
Yep.
That would include in this number.
See, I live 300 yards from it, and I just want to have the welcome bag ready. Okay.
Excellent.
Thank you.
Thank you.
Representative Weber.
Thank you, and thank you for taking my question. This is close to my heart also because my other volunteer job is as a CASA. And my understanding was that as of this morning, there were only 3 residential beds at Hempstead for children.
There are 3 psychiatric residential treatment
Right.
beds at Hampstead currently filled, correct?
And
Follow-up.
my follow-up, thank you,
Follow-up,
Mr.
yeah,
Chairman.
sure.
I guess my question is really thinking about down the line. My understanding is that there is very little level 4, level 5 care in state at all. And are there plans to do anything about that, or is that something that we're just waiting to get to?
Yeah, certainly plans. I do want to reflect that at Hampstead there are 12 beds for the psychiatric residential treatment facility. Right now, due to staffing, 3 beds are currently filled. We have built into our commissioner roadmap, and I do want to sort of drop some of that conversation around the roadmap. Does have a specific strategy and deliverable to support the continued expansion of those beds. Not past the 12, but to ensure that we're
Right.
filling them in their entirety. But I do want to make a comment. It is absolutely correct that we do have very few beds at level 4 and level 5, and ensuring that those are filled will help us tremendously to bring youth closer to their home and community.
Representative Woods.
Thank you, Mr. Chair, and thank you for taking that question. Obviously, the goal is to integrate, have treatment available, but to integrate these kids into their normal flow of education and social activity. Are there any impediments in making that transition or working with any of the educational institutions, either private, voucher schools, regular, public schools? Are there impediments there that we should be paying attention to?
Yeah, that's a loaded question. I think with a lot of factors potentially. So I could probably answer that with a bit of a thesis, to be honest. But I think anecdotally what we see quite often is some of those impediments come down to communication, planning, care coordination, and those strong connections. So ensuring that we have programs that are bridging those gaps, helping to support families, connect with their schools, connect with community-based resources, it has been critical to reducing length of stay and to ensure that we have a good transition plan back home. I think for scenarios where that doesn't go well, we tend to have a lack of care coordination, a lack of coordination in that capacity. And I could probably say a number of other factors, but that's probably one of the largest ones that we tend to see.
Follow up?
Yeah, would that be something that is worth a closer look?
I certainly feel like it's under our review quite often. When I reference the transitional enhanced care coordination model, that is something that we have had a lot of success with, and the goal of that program is to ensure that youth are transitioning from a residential setting back into their community as effectively as possible. So there has been a significant lens on that particular piece.
Well, I'll be sorry. I just closing comment. My question is centered around. We've had a lot of transition from public schools to voucher schools, and there's been some question of how well that transition is functioning. And I think with the tax dollars being shifted from the public sector to the voucher system, I think it's worthwhile to see if, in fact, this particular aspect is being met in a way that would be consistent with your goals in terms of what you need and what the children need, because we're really here to take care of the children.
Exactly.
So,
yeah.
And I think it behooves us to see how our system is working in all its dimensions. Thank you.
I would be interested in that too, because while I can certainly take the point that this may be a negative move for some children, I have stories told me, it's anecdotal, but anecdotes lead to statistics, that it is a life giver, lifesaver. So it could wash, I don't know. It could be tilted one way or the other, I don't know. But sure, these are tax dollars. They're not called vouchers, but they're vouchers. Let's see if they work in that area, which is not the sum total of its merit or lack of merit, but it is, to me, a data point. And I'd love to see some investigation on this presented to us at some point. Senator Rosenwald.
Thank you, Mr. Chair. I think I heard you say that due to staffing challenges, only 3 beds of the 12 of the PRTP are having children in them. Is Dartmouth in compliance with the contract on that issue? I mean, I know that with the previous vendor, WellPath, I think it was called, they had been out of compliance because so few beds were staffed, and the department had sent them a letter of non-compliance. What's going on with the PRTP?
Yeah, PRTF, so Psychiatric Residential Treatment Facility. For the notes, my understanding is that they are in compliance. We work very closely with Dartmouth and Hampstead Hospital. They're continuously hiring staffing and working towards building those bed capacity. It's been a tough transition from that aspect. Although they have had some great success in terms of building staff for their PRTF, especially most recently, there was a period of time where they actually paused admissions to be able to get their staffing in order, and that plan has continued to work and move forward. So we do anticipate that those beds will continue to increase as staffing continues to build and increase. And we keep a pulse on that through huddles, through collaborative conversations. DHHS meets with Hampstead very frequently.
Comment, if I could. I mean, it just seems like if we built this 12-bed facility, which I know we built, and then we immediately renovated, why are we accepting of the fact that only 3 beds can be filled right now by the contractor? Shouldn't all, 8 of these kids, if that's the level of care they need and not hospitalization, shouldn't all of those beds be filled?
Certainly striving towards all of those beds being filled. Yes.
Some of the difficulties faced prior to the Dartmouth takeover, I know have been taken care of, which should make it a much more attractive place for people to come to work. Wouldn't you agree?
Agreed, and I think there's some incentives that Hampstead, and I don't want to sit here and speak for Hampstead in particular and Dartmouth, but they've built in some incentives to help draw in some of that staff.
Well, the number of assaults is down of staff.
For sure. Yeah. Great. Well, thank you for your questions. If it's okay, I'll shift to slide 7, which is really looking closely at the emergency department waiting and how many children, really the trend line for children waiting in the emergency departments over time. You will see that this graph shows from January 1st, 2023. I almost put data in from 2020. I wanted to get a little bit closer with some of that data, but I didn't want to convolute some of the data trend lines because COVID tended to spike that up significantly. But you can see here from 2023 through October 1, we do continue to see a consistent trend line decreasing for youth waiting in the emergency departments. That is an effort that we continue to build into several initiatives, including our Commissioner's Roadmap as well. Building in a Youth Mission Zero initiative will be critical in our next roadmap over the next 2 years. We do keep a pulse on this metric on a daily basis. You can see here that it's quite a roller coaster from month to month. You can see some very high points, some very low points. But I can sit here today and say we did reach zero several times in the last 6 months, particularly over the summer, and we more often than not we're in single digits. What's even more important is understanding the time in which a youth is waiting in an emergency department. So this is tracking not just really just primarily the number or the total number of youth in an emergency department waiting. But what we're looking at very closely is the time in which a child is waiting in an ED. That I don't have the exact time in front of me today, but I know from our conversations with Dartmouth and Hampstead Hospital that number continues to significantly reduce as well.
There's being in an ED and there's being in an ED. One is you're there because you need the treatment and are receiving it. The other is we don't know where to put you and you're in the hall. So are these numbers, which are these numbers, or are they both?
It really captures both in many ways, yes. If a youth is in an emergency department waiting for a level of care, then it will capture this. We do know that there are youth that are in an ED waiting to transition back to the community. This number might not reflect every single child, but for children that are being contemplated for a higher level acute psychiatric treatment, it is capturing that number.
Given the lawsuit, it would be helpful for me to know the difference. If you're there being treated actively, great, that's why those beds are there.
Right.
If you're not, because we don't know where to put you, or we know where to put you, but that's all full up too, that would be an interesting number to have as well. If that stat could be broken out.
Yeah, noted, thank you.
And if you could email us that when you have it, thank you.
One thing I want to recognize here too, and Carolyn will talk a bit about
Before
it.
you go,
I'm sorry.
Senator Gray.
There does seem to be, if you break this out, some cyclic nature about times during the year. Have you guys investigated that to see, what's going on? Because it appears that, the March time frame seems to be, when you look at the overall numbers, there's a low point for the year, and the September time frame, again, have you looked at the cyclic nature?
Yeah, we've that calls out like a bright bulb. We have other data, referral data for our intensive programs like Fast Forward that follow a very similar trajectory. I would say our crisis referrals also follow a very similar trajectory. It seems as if it follows a lull in the summer pathway. it's hard to conjecture exactly why that's the case. Youth tend to be out of school at that time period, and that's not me sitting here blaming school as a primary factor, but acknowledging that school may have an impact. What the factor school has an impact on children's behavioral health and family health. Seemingly from that trend, that could be pulled out.
Representative Lamontagne.
Thank you, Mr. Chair. Yeah, I had a similar question about that. I'm looking at the dip in the summertime and wondering if is it a matter of reporting, like you have schools more involved in recognizing a behavioral crisis and making referrals, or is school itself often the triggering thing?
Yeah.
I'd be very curious about that. But earlier, I was just wondering, how does this process work typically? Is often a family bringing a child to the emergency department what starts them being involved in the whole process, or for children involved in these community health programs, how often is that? Is it started in school more likely? Or can you just give an overview of
Yeah, no, I appreciate that question. Happy to. I think we have a number of community providers that often are responding in crisis. I partly where I was going with my comment before I interrupted Senator Gray. We will talk a bit about our statewide crisis system. Carolyn will speak to that a little bit in some of that overview. But what I can say is for children, that has been a more consistent pathway to gain crisis support first and early. So when a crisis is occurring, calling 988, getting connected to our statewide access point has been our primary communication. So if a youth is in a school setting, if a youth is in a home setting, a community setting, we want families to be calling that crisis access point to get their needs met as early as possible. There's certainly a correlation with our statewide efforts for crisis and how this data trend continues to go down. I think we are trying to catch youth early as possible and avoid families needing to go to the EDs for that crisis purpose. We're also finding in our trend data, and we didn't supply that here, children tend to have more mobile deployments, meaning they're calling the access point for a crisis. They receive some level of triage, and the access point determines that they could use a mobile dispatch or a mobile deployment from their local community mental health center, or a local community mental health center, and a team goes out there and diffuses that crisis.
Mr. Tenney, before you go on, I want to pick up a phrase that's been used several times now, 10-year plan. I'm more familiar with the 10-year plan from the transportation folks because the family practice medicine / counseling / massage center I'm CEO of is right on Route 125 in Kingston. And it's right sort of on the bubble. And I know watching 10-year plans for several years, there is less likelihood that what's at year 8, 9, and 10 is going to happen than what is years 1, 2, and 3. But you need to have a 10-year plan for planning purposes. So I've come to learn watching those 10-year plans, there is a relatively growing fluidity as we go further out. Would that be true for the mental health 10-year plan? That's not a bad thing. It's just, to me, normal. But
yeah,
is that what you have?
Certainly normal. We'll talk a little bit about briefly about some of the next steps and thinking about. I mean, it's hard to believe that we're in year 7 of a 10-year mental health plan, but we are really thinking of and working towards year 8, 9, and 10 and planning.
But do you not have a 10-year plan with 7 more years added on the other end, and it's always 10 years, and 1 year drops off and 1 year adds on? That's what they do at transportation. I'm not sure whether you do that or not.
So we're at year 7 of our 10-year mental health plan. So we are what I'm saying, and what we'll talk to you about next steps is that we'll talk a little bit about years 8, 9, and 10, it really getting us trending towards the next 10 years, the next plan.
And the next 10-year plan has not been conceived or promulgated?
Not at this time.
Okay, that answers my question.
But part of that 3-year, the last 3 years of planning will include planning for those next steps.
Okay. Representative Weber.
I was just going to note that we don't update the 10-year plans for mental health the same way we do the 10-year plans, which are transportation plans. There's a whole new set of hearings every 2 years.
Right.
And everything changes. And we have one plan, and we're partway through it.
Exactly.
That's helpful. Thank you. Thank you so much.
Appreciate it.
Mr. Tenney, please continue.
Thank you very much. So great pause moment. I will hand it over to my counterpart, Carolyn.
Thank you, counterpart, for being here.
Thank you very much. I'm delighted to be here, and I'm excited to see that you are all so interested and so invested in the information that we're providing for you. So thank you very much for that. As Daryl has talked about with the children and families, I'm going to spend just a few minutes talking about the adult system, where we are also seeing measurable system-wide progress. And I want to start with talking about Mission Zero, which, as you know, is the collaborative effort to eliminate individuals waiting in the emergency room for psychiatric admission. And Mission Zero did, in fact, hit 0 this year. But more importantly, I wanted to just say that 94% of the time, there were less than 10 people waiting in the EDs for psychiatric admission, which shows a tremendous improvement from where we started. So there may be 11 days where we actually hit 0. That is not entirely the picture, which means that there are far fewer people waiting for far less time. And these efforts, a lot of the things that we'll continue to talk about, that we have talked about, are really aligned with the DHHS roadmap. So timely access to care, safe transitions back into the community, these are all consistent with the roadmap. The second element I want to speak to a little bit about, and Daryl alluded to it earlier, is with the Certified Community Behavioral Health Clinics, the CBHCs. And this year, we have now 3 certified clinics, and they are certified under the Federal Medicaid Demonstration Program. They're delivering 24/7 crisis care, rapid access to treatment, and whole person services. And this is exactly the kind of upstream, community-based, prioritized in the DHHS roadmap.
And where are they located, please?
The West Central Behavioral Health is the latest one. And then we also have Manchester, Greater Health Center, Mental Health Center, Greater Manchester, and Nashua.
I missed the town, the city.
West Central Behavioral Health is in Claremont.
Claremont.
And Manchester and Nashua. And I want to now draw your attention to the next slide, which is slide 9, the rapid response system slide. And what you can see from that slide is
Yes, this one.
Where? Okay.
Yeah, keep going.
I see housing as the headline.
You have to turn it over the other way.
Supported.
The other side, the facing page for housing is the rapid response access.
Got it.
page.
Thank you.
Yes.
Yep. Okay.
Okay.
Having a brain cramp. Thank you.
So the system handled over 33,000 calls in 2024, which is 33,000 times somebody reached out for support and was able to get that. And notably about those 33,000, 75% of the time, that connection with the access point was all they needed. It was only 25% that they needed something additional, a deployment after that. So that's an awful lot of support right there, right in the community, right in the moment when individuals are needing it, to help get them connected to the services that they need. So the next slide, slide 10, housing, which is on the facing page. Housing remains one of our most important and powerful tools for recovery. Individuals transitioning from hospitals or homelessness into stable supported housing will also support reducing ED boarding, shortening inpatient stays, and supporting long-term recovery and reintegration. And you can see in slide 10 the growth in the number of supports that we have available in the community. And these are really measurable outcomes. They are saving both lives and public dollars.
Senator Rosenwald.
Thank you, Mr. Chairman. So, House Bill 2 requires the sale of the Philbrook building, which housed 24 beds, I think, of some number of beds, about that, of transitional housing. How is the progress going towards finding another site for those individuals to leave so that we could complete the sale?
We have issued an RFP, and we are in the process of collecting questions and responding to those questions from the RFP.
Timing?
I'm not sure the exact timing. I'll have to get back to you on that.
Thank you.
There's growing chatter that sale may not happen. I'll leave it at that.
I'm sorry, which sale is this? And I'm asking which sale are we talking about? Philbrook, okay.
Please continue.
Thank you very much. So the next slide is representing peer support agencies. And peer support agencies are really a cornerstone of our behavioral health system. These are not ancillary services. They are essential services that have individuals with lived experiences, offering support to individuals, building trust in the system. It prevents escalation and keeps people connected to care. And as you can see in slide 11, peers support an increasing number of individuals each year. And I want to highlight as well that you can see with the warm line and the peer support line that 43,000 times individuals reached out and received support through those lines. And their expansion reflects the legislature's commitment to community-based and person-centered care. And this is another powerful example of how the 10-year plan and the DHHS roadmap are in action. One of the probably most impactful interventions that we have now is with the Strongest Granite campaign. And you'll see some data on slide 11, and you also have in front of you some materials that we have that we are able to provide to the community reflecting the Strongest Granite campaign. And this really goes very far in reducing stigma, raising awareness, reinforcing the idea of early help seeking and community resilience. And I want to share one data point that's not reflected in the slide. It came in a little too late for us to put it on there, but we talk about the number of impressions, which you have on there, but also when an individual in New Hampshire goes on their computer and searches for information about suicide, what we know from the data is that 132,000 times in the state of New Hampshire, when somebody went to their computer and typed in a question about suicide, perhaps they're contemplating it, 132,000 times Strongest Granite and 988 popped up for them in that moment and in that instant. And I just think that's a really powerful example of getting to people in the community in the moment when they could most use that support. So together, we've built a more connected, responsive, and transparent system, one that reflects New Hampshire's values of partnership, efficiency, and community resilience. And your continued leadership is essential as we complete this work and plan for the future. And just in closing, we want to thank you for your time today. We are so delighted to have the opportunity to share some of the meaningful progress we've made in strengthening its behavioral health system and advancing the goals of the 10-year plan. And as you alluded to earlier, Representative, and as Commissioner Weaver emphasized in her roadmap, our priorities for the final years of the 10-year plan are very, very clear. We want to strengthen and sustain the crisis system, streamline and integrate access points, use real-time data for oversight and quality
I'm
management.
sorry, could you do these much slower so I can get them
sure
down
could.
because they're critical?
Sure.
Starting at the beginning.
Strengthen and sustain the crisis system. Thank you. Streamline and integrate access points. Use real-time data for oversight and quality improvement. Expand prevention and early intervention.
Thank you.
You're welcome. And we want to thank you for your continued leadership as we complete this work and plan for the future.
Any further questions? Representative Lamontagne.
Thank you, Mr. Chair. I just have one quick question. Why would someone call 211 versus 988?
211 would tap an individual into the doorways, which provides substance use support. So if they know that that's what they're needing and that's what they're wanting to connect to, they can go right to 211. If they're not sure and they call 988 and the person they talk to on the other end determines that 211 would be the appropriate place for them to go next, they are directed to 211.
Anyone? Thank you so much.
Thank you.
And I look forward to those breakouts. Yeah, thank you. Let's see. And Melissa Hardy, Division Director, Division of Long-Term Supports and Services, and Jessica Gorton, Director, DLTSS, Bureau of Developmental Services. Does that fit on one business card or two?
Multiple lines on a business card, yes, front and back. Thank you for having us back. Like you said, I'm Melissa Hardy. I'm the Division Director for Long-Term Supports and Services. And I'm Jessica Gorton, the Bureau Chief for the Bureau of Developmental Services. So we are happy to report on our quarterly waitlist numbers for the developmental disabilities waiver, the acquired brain disorder waiver, and the in-home supports waiver.
And do you have a handout?
Yes.
And what does it look
Should
like?
look like
No. 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 Yep.
perfect.
This one.
Okay. So as we usually start out, we are looking at fiscal year 25 for the fourth quarter. So we're reporting that data out at this time. All of the requests for funding for individuals for those three waivers were funded during that quarter. So there was nobody that was not funded. What we've learned throughout the years in reporting to this committee is to really boil down why people were funded but not started on services. So that's what you'll see here today is a breakdown of people tracking that we've been doing. So we're excited to hopefully get that completely up and running within the next couple of months, so we can have this data at our fingertips instead of counting and repeated conversations with our partners. So we're excited for that to start. We'll start with the developmental disabilities waiver. So in quarter 4 of 25, funds were requested for 158 new individuals for DD waiver services. And we, like I said, we did allocate funds for all of those 158 requests. You can see in that first blue box there, A's, we categorize people within our statute. So individuals who are considered A's are adults who are exiting school. So now starting in our system from kind of like coming from school into adult services. Our B's are individuals who are newly eligible to the developmental services system. So that could be somebody who's an adult that moved, from another state into New Hampshire, who are eligible now for New Hampshire services. So we do break it down as far as who was funded and requested services. From that 158 individuals that funds were allocated for in quarter four, 64 of those individuals withdrew their request for services.
And why might that be?
Yes. So in looking at the months that this quarter reports on, so that's April, May, and June, there are opportunities for people who are 18 to remain in school longer. So we'll see that number typically a bit higher in quarter four and in quarter one as people who might have planned to exit school and enter our system stay in the school system and they can stay up to the age of 22. So usually it's a trend that we do see, and some of the smaller reasons why people might move out of state or just a family chooses to take care of their aging child that's coming into the community on their own and pause services, but mostly we see people staying in school. Of the remaining 94 individuals, 86 were projected to have their services start within quarter four. On page 2, we break down those 86 individuals where 67 individuals started services and 19 individuals did not start services. And so on that second graph on page 2, we were able to break down why those 19 individuals who were funded, who were projected to start, were not started. And so you can see there that the top reasons are individuals that are waiting for Medicaid eligibility, or their Medicaid look back isn't complete, and then looking at provider and service agreements not completed. So in looking at the number of individuals waiting for Medicaid or Medicaid look back, that's 17 total out of the 19. And looking at who those individuals are, currently 8 of those individuals Medicaid is currently open as of now. So again, this is kind of older data from last fiscal year's last quarter, but we still keep track to make sure that anyone who's awaiting Medicaid eligibility, that the department is helping them with that process. Any questions about the DD waiver waitlist information? All right, we'll move on to the in-home supports waiver. So that's children who need supports through the Bureau of Developmental Services. So in quarter four, there were 40 new individuals that requested services. 7 of those individuals withdrew their request, and which leaves 33 individuals who started services. They're either receiving full or partial services. The remaining 7 individuals that did not start did end up starting in quarter 1 of 26. So they are started services. They just didn't start in the quarter we expected them to start. And lastly, the acquired brain disorder waiver. There were 6 individuals that requested and were funded for services. 2 individuals withdrew their services. And so that remains 4 individuals total. 3 did start services in quarter 4 of 25, with 1 still waiting for services to start in this quarter. However, again, looking at the data, that individual did start in the subsequent quarter. On page 3, we talk a little bit about some, reasons why there's delayed starts in some of our remediation efforts. Like we talked about earlier, the top 2 primary factors in this quarter were awaiting Medicaid eligibility and the Medicaid lookback. So we talked a little bit about that. I do want to plug the department's roadmap, which is commitment 3, initiative 1, to improve customer service to make eligibility easier, which the initiative will help individuals and families understand the Medicaid process in plain language. We're streamlining some of our own processes within the department. So we really are excited to work on this roadmap item and see an impact on individuals' Medicaid starting sooner to their application date. So it ties into not only Medicaid at large, but certainly all of our folks on the waiver. We've reported before we were allocated money from the ARPA funding, and we invested money into workforce for our home and community-based providers. Those grants do end at the end of this year, so December 31st, that money needs to be spent on staffing, recruiting, retention efforts. The department, we're working with the Administration for Community Living in a peer learning collaborative, which is looking at the reports that these grantees are submitting to us monthly and measuring the impact of those grant funds and what they use those grant funds for. So we hope to have some more information after that peer learning collaborative group that we're working with gives us some information on how well it worked and what can we use moving forward to keep those efforts positive for growing the direct care workforce. And then for BDS, we facilitate a lot of meetings. We're always in meetings, but weekly meetings with service coordination agencies. We talk to individuals, families. We talk about service authorizations. We talk with our area agencies, really to keep that clear line of communication open between not only us at the department, but our providers, our vendors, and our individuals and families. Lastly, we have a DHHS interdepartmental collaboration. So BDS, along with the Bureau of Family Assistance, are working together. The Bureau of Family Assistance houses the Disability Determination Unit. So they determine somebody's level of disability based on their medical history and social history. And so what our area agencies do, they also collect some of that information when they're determining if somebody is eligible for developmental services information. So we're working to see the information that the area agencies collect at intake and eligibility, how that can be used to speed up the process for a disability determination, where we see some crossover information there. So hopefully streamlining that not only for the individuals applying for disability, but also for the department and for people to be able to get their Medicaid benefits quicker rather than submitting information they've submitted previously. So that's our quick update.
Senator Rosenwald.
Thank you, Mr. Chairman. Actually, I have 2 questions.
Start with number 1.
Number 1 is there for the DD waiver programs or the ABD, is there a statutory time frame in which the department has to make the determination the way there is for the long-term care waiver?
Do you mean a determination for waiver eligibility or Medicaid eligibility?
Well, if somebody is applying for Medicaid because they have a developmental disability or acquired brain disorder, is there a statutory time limit within which the department is required to make that determination? I know there is for the long-term care waiver.
I don't believe there's any additional accelerated process for those who are, applying for the DD waiver or the ABD waiver for their Medicaid eligibility to be determined quicker than what's in the statute.
I'm sorry, I think I didn't ask that correctly.
1A.
Let's say I am in a motorcycle accident, have an acquired brain disorder, apply for Medicaid. Is there a time limit within which the department has to make a determination on my application at all in statute?
Yeah, I would have to take that back and ask the Bureau of Family Assistance. I believe there's certainly timeframes from application to completion, or a decision. I will say in a circumstance like that, something tragic like that, we get reach out daily from those situations for people who are in crisis. And so we certainly, help those individuals submit a complete application. We work with the Bureau of Family Assistance, to make sure either an individual like you quoted, or, somebody who's aging that's, they could be in risk of being institutionalized or hospitalized longer. Internally, we don't have kind of a ranking process, but we certainly would, add different resources to make sure that somebody is safe and have what they need, on a case-by-case basis. But I don't believe there's anything on our end for BDS that's regulatory or statutorily mandated.
Okay.
Would you like to try what's next? 2.
Yeah.
Could I just finish up with 1B?
1. Actually, it's 1A.
So no, she had 1A. I'm on 1B.
Oh,
And thank you for sticking with us. You have twice referenced that there is a time frame statutorily from the beginning to the end, and I'm just wondering what that is, because I thought that was what the question was.
So
That is sort of
beginning to end for Medicaid determination. So once you apply,
Okay, so it's the standard Medicaid.
right?
and
Once
that
you
is how
apply
long.
and have a complete application, there are statutory time limits as to the department when Medicaid eligibility has to be determined.
Okay. And do you happen to know what that is off the top of your head?
I don't. I don't want to I don't, but I can certainly get that information.
If you would, and just
Yeah.
one final thing.
Would this be part of B or C?
No,
I'll
C, it's C, yes. 1C.
My final question is the issue mostly getting to the stage of a complete application, which is the thing that triggers the time limits, and which is often the thing that takes the most time.
Yes, I would say getting a complete application is key. And once a worker is starting to look at that information that's submitted, there might be additional questions, as they start looking into financial information. So I think definitely, date of application is different than date of completed application,
Right.
which is different than date of application being either approved or denied based on that information. There's a lot of back and forth with families and the department as far as what's needed to complete an application. And that's really why it's a priority on the roadmap, because it does take some time, which does hinder, for example, a waiver service started. We can't start a waiver service unless somebody is on Medicaid and have their look back completed. So we're doing a lot of work surrounding making that process easier and more user-friendly, not only from a technology standpoint, but using user-friendly language and what we're asking for families or individuals for information.
That's 1D.
This will be 1D.
Thank you. Is the statutory time frame, which I think is 90 days.
I think
Right.
so, but I don't want to be quoted that. Yeah.
Does that encompass both financial eligibility and medical eligibility?
Yes.
And the financial comes first, right?
Generally, yes, the financial does come first, but you know, if we know somebody that's, you know, being redetermined, they've already had Medicaid, we can certainly start looking at the financial side. The medical side before financial is done. But yes, generally the financial is done first. It is the longer part of the process, and then for medical eligibility for the DD waivers done by the area agencies, for CFI done by a contractor in the department.
Anybody with 1E? Seeing none. Moving right along to question 2.
Thank you.
Welcome.
So I'm aware of the look back provision, the 5-year look back for the long-term care waiver, but I was not aware that other programs, waiver programs, had a look back. Is that in state law or federal law? When did that happen?
Yeah, it is in federal law for all of our waivers for that look back period. So it does impact our developmental services waivers for somebody to be financially eligible for Medicaid.
2A?
Yes, thank you. So children's income is generally discounted for the in-home support waiver, right? Because they don't have any income. So what are you looking back at?
It's a great question. I don't know, Jess, if you want to answer that.
With some familiarity, because in a previous life, I worked over in the Bureau of Family Assistance, so the income and the assets are treated differently. And there are some instances where children may have some assets in their name, some special needs trusts, some bank accounts that have been established either by their family members or someone else. So they would look to see if those things exist, and sometimes they don't, and it's a relatively fast process, and sometimes they do, and they would have to go through that interaction.
Thank you.
Any other questions? They won't be number 3 because the numbering system is for the senator. But any questions further? I've got one. I'm in year 9 in the House. In my first 4 years, I was fairly well involved with the area agencies and DD and so on, and I'm more doing other things now. How, in general, are the area agencies performing? And that's, you know, I want a generalized statement because individual problems are dealt with appropriately, but I just want to say, what are the hurdles, if there are, that area agencies have?
I think that, you know, when I first started, we had a lot of conversations about, you know, our compliance and kind of system redesign, and I think you had a lot of outreach from area agencies about their concerns to that process. I do think over this past year and a half, they've been able to streamline their processes to match what we have at the state and what our regulations are under CMS. And I think we've been able to develop a better, I would say a great working relationship with all of our 10 area agencies. We communicate at least monthly with each of them one-on-one. We attend their monthly board meetings and of course are, you know, available to them at any time. So I do think over the years we've built that relationship with them, where if they do have a concern or if they do see something kind of, you know, going down a road that they don't want to go, they do reach out to us and we troubleshoot together. So I would say that our relationship has definitely improved over the years.
That's what I see from the distance.
Great.
Thank you.
Thank you.
Keep going.
That's all I have.
That's it?
That's it?
Well, don't be a stranger. Come back
Okay.
some other time.
Thank you.
Thank you so
Appreciate it.
much. I looked at this and I thought it said newborn screaming. But indeed it is.
That happens.
But you're going to get to.
But they're going to have the diapers because I
You're
signed
getting
on
to
to
the
that.
bottom of it.
Yes, thank you. Newborn screening. Annual report, Courtney Kane, Administrator, Division of Public Health Services. Welcome.
Welcome. So for the record, I'm Courtney Keene, Bureau Chief for Family Health and Nutrition within the Division of Public Health. I want to thank you for the opportunity to be here today and to present the newborn screening report. The newborn screening program operates under RSA 132.10a.
I'm sorry, if I may. Do we have a handout for this,
Oh,
or is this something
absolutely.
that was, and
Just
what,
going
just
to
what does
ask
it look
them.
like?
Sorry, should have done that from the beginning. Would you like a color copy? They're over there.
It's
Got
the
it,
one that
got it. Thank you.
it's
The one with
that
baby
talks
feet
about
on it.
newborn screening. How about
Correct.
that? Who saw
Sorry,
that
too much
coming?
paper
No,
in front of me. Thank
that's
you very
fine.
much for the
Yes.
indulgence, both of you.
Calendar year 2023.
Yes. So I'll get into that,
Good
but it's
eye.
because of confirmation of disorders. It takes about 2 years to confirm the disorders.
But they're not newborn by then.
You are correct. They are not.
Sorry.
That's okay. So under RSA 132.10a, newborns in New Hampshire are screened for a panel of serious but treatable conditions. Within the RSA, parents or guardians have the option to decline the screening. The goal of newborn screening is to identify before symptoms begin so early treatment can start to prevent serious health problems, disability, or death. Conditions included in the screening panel for New Hampshire are chosen through an evidence-based process defined by statute. The program ensures that screening infants for heritable conditions is done timely and their results are reviewed daily and abnormal results are shared with the provider and make sure that a referral to a specialist is done. So this report is for 2023. Due to the length of time for diagnostic confirmation, the data is typically 2 years behind to ensure accuracy and completeness. So in 2023, the program screened 11,976 infants out of 12,070 births in New Hampshire. This represents a 99% screening rate. The remaining 1% of infants who were not screened are due to declinations, infants' death before screening, transferred out of state, and other. The other category includes a small number of unique situations, such as screenings done using another state's filter paper, that is the card that the blood is collected on, and then screenings performed through private laboratories. The program followed up on 656 abnormal results. So we tracked 656 babies after their screening was done. Of those, we confirmed 29 cases in 2023. The care of infants with abnormal newborn screening results requires close collaboration amongst a range of healthcare providers, including neonatologists, primary care providers, metabolic specialists, and genetic counselors. Access to expert consultation is critical to support providers in confirming diagnosis, making timely referrals, and managing ongoing care effectively. The newborn screening team is dedicated to ensuring effective program coordination and follow-up. State staff includes a nurse consultant, a quality improvement specialist, and a nurse program specialist. The program contracts with Dr. Kritzer, a metabolic specialist. She provides clinical consultation and recommendation for newborns with abnormal screening results and programmatic guidance on clinical policies. The program contracts with the University of Massachusetts Chan Medical School. UMass provides laboratory and logistical support. UMass supplies the filter papers, the cards the sample is collected on, to birth facilities and midwives, conducts laboratory testing and follow-up recommendations. Together, newborn screening staff, contractors, form a comprehensive team to ensure that every newborn with an abnormal screening result receives timely evaluation, referral, and ongoing support. The newborn screening program continuously works on quality improvement activities. A couple of key improvements include a 4% reduction in missing demographic information on the filter papers, screening timeliness, increased to 98.7%, surpassing the national benchmark of 95%. The program, based off of previous quality improvement activities, plans for future years. Upcoming plans include development and distribution of educational materials for providers, birth facilities, and midwives, streamlining newborn screening requests for results, and continued collaboration with midwives and birth centers on the timeliness of screening. The newborn screening field is rapidly evolving, shaped by advances in technology. As innovations emerge, the newborn screening program remains committed to updating policies, enhancing resources, and strengthening infrastructure so that New Hampshire's newborns continue to benefit from the latest advancements in early detection and treatment. Thank you for the opportunity, and I am happy to answer any questions you might have.
Ms. Keene is happy. Do we have a question? To further her happiness, Representative Woods.
Thank you, Mr. Chair. Thanks for taking my question. There's a lot of changes occurring, and one of which is at the federal level. How is that going to impact, as it's my understanding that the federal oversight of this type of thing is being withdrawn. Is that both in principle and policy as well as in any funds?
I'm going to ask a clarifying question. Are you referring to the RUS, the Recommended Uniform Screening Panel?
Yeah.
Yes. So funding-wise, it does not impact the state of New Hampshire. As far as advancements in conditions being added to our panel, there is a potential. We go based off of what is recommended. So we're kind of in the middle right now of what the next steps will be, but it won't impact what is currently being screened for.
So going forward, there's no risk that this program would falter?
No.
Good, thank you.
Thank you, that was very easy.
Before we adjourn, just to point out to you in your packet, you have the most recent update for the New Hampshire Division of Children, Youth, and Families, DBA DCYF. It's their monthly data. Remember, this had been asked for quite some time ago and has been now generated, but you get the latest one here that should answer some questions. And there we are. We already have our rough agenda for the next 2 months, subject to a few things dropping off and a few things dropping on. And if there's anything that you think we really could profitably hear from, let us know, and we can get that onto the schedule. Because unlike the 10-year plan, this is a 12-month plan with time off for good behavior in the summer, and it is fluid. And I think this is the 5th iteration of the schedule for this month, Councillor, wouldn't you say? But it's right up to date. So let me know, and there we go. With that, I conclude the meeting.